So we all know bucket handle tear are most commonly seen in the posterior horn of either medial meniscus or lateral meniscus. But this is some unusual case of chronic retracted bucket handle tear of anterior horn of lateral meniscus. So she is a 45-year-old lady who came with a chronic knee pain and effusion since last 6 months. History of sudden jerk and while climbing down the stairs, no instability or giving way. She tried conservative treatment for almost 5 to 6 months, but it was of no use. She had synovitis, swelling, and pain. The X-rays were absolutely normal. There was moderate effusion and anterolateral joint line tenderness. Collaterals, ligaments, alignment, and everything was quite normal. So this was her MRI picture, which shows effusion and some signal changes in the anterior horn of the lateral meniscus. But if you see the sagittal sections, something was missing. There was no proper lateral meniscus on the anterior aspect. And the report shows it was quite unstable meniscus anteriorly. So when I went in, this was the picture. So the rest of the collaterals and everything was normal, and this was a chronic retracted anterior horn of lateral meniscus bucket handle tear. So where you can clearly visualize the whole anterolateral tibia. So I used shaver blade. See that it should be on a non-suction or minimum suction, less aggressive shaver blade, so that you don't damage the normal meniscal tissue. So as soon as I cleared minimum clearance, you can see the whole anterolateral tibia was exposed. So thing is how to get it back, because she is quite not that old, 45 years old lady with all normal alignment. Went in and you see the reducibility of that meniscus first. So meniscus was reducible but unstable, was going back almost in the mid-coronal plane, getting reduced but was quite unstable going back. So with routine outside-in technique, what we use with the help of our 18 number spinal needle or meniscal mender set, in that the meniscus is often reducible and stable. It doesn't keep moving in and out. So it's quite easy for us to take a bite from outside in with the 18 number needles along with the fiber wire, and the another needle coming out through the substance of the meniscus with the loop of ethylene or proline, and then you shuttle relay the fiber wire from outside in. But here, as the meniscus was quite retracted, it was difficult to get the routine outside in technique. So what I did, I took the 18 number spinal needle, came out percutaneously anterolaterally, took out that fiber wire through the lower anterolateral portal, and then loaded that fiber wire onto a all inside device like knee scorpion, and then passed that fiber wire through the good anterior horn or anterior substance of lateral meniscus. Now here comes that both outside in and all inside came here. Now you need to shuttle relay that fiber wire which I took bite, and it's in the anterolateral portal. So again used an 18 number spinal needle from percutaneously anterolaterally. See that the loop here, whenever you want to take a bite, get maximum vertical stitch. So the 18 number spinal needle along with the ethylene loop should come as vertical to the first bite percutaneously as possible, so that you get a vertical stitch which is quite robust and stable. So here you see again I came percutaneously with the number 1 ethylene loop. Now you need to pass your 2-0 fiber wire or 0 fiber wire from the anterolateral portal through this ethylene loop, so that you can pull that fiber wire again percutaneously out of the anterolateral capsule. Being a retracted routine outside in technique was not possible, hence it was modified to modified outside in technique. The whole purpose of showing is that you should have all this armamentarium in your bucket whenever you are trying to do any meniscus repair, inside out, outside in, all inside. And then sequentially I tied everything from posterior to anterior aspect, because if you tie suddenly anteriorly, there are high chance that it will cut through. So you need to do sequential reduction of the meniscus from posterior to the anterior aspect. And that's what, after whole meniscus repair from posterior to the anterior, the meniscus got stable in anterior aspect. Unlike what we see in the posterior, we need to use all inside meniscus device because the access to inside out and outside in is little difficult. And this is what all percutaneously 4 fiber wires were passed from outside in, and then modified it and tied percutaneously. Anything anterior horn repair, the knee should be flexed in 90 degree and then tie on the capsule. If you keep knee in extension and do anterior horn repairs, patient will be having stiffness and loss of flexion because the capsule tends to stretch in flexion. So in anterior horn, tie it in 90 degrees of flexion. And this is the technique which has been recently accepted in arthroscopy technique as a modified outside. So it's post-op 6 months now, patient is absolutely all right, doing all activities. Thank you.